Hi, and welcome to another episode of the live Homage Web Series. Thank you for joining us in this session, and today we'll be talking to Professor Sibrandes Poppema. Professor Poppema is currently the President of Sunway University and advisor to the Chancellor. Previously, he was also the President of the University of Groningen, a global top 100 university. He is also a specialist in immunopathology and is in the top 2% of the most cited authors in the world in the field of immunology. Today, he's here to discuss the science of vaccines, herd immunity, and answering some lingering questions regarding the COVID-19 vaccine. So without further ado, let's hear from our anchor PC Gun and our very esteemed guest, Professor Poppema.
Good morning, Selamat.
Hello, Professor. Thank you so much for taking the time in speaking to us. So I think for the general viewers out there, thank you for tuning in. We also want to let you know that this health information is provided for general information, and this video only represents the speaker's view on COVID-19 and its vaccine. Okay, so without further ado, let's jump quickly straight to the first question, right? Professor, if you can just let us know what does vaccine means and if it means 100% protection.
Yes, that's a good question, or both are good questions. A vaccine basically is anything that is mimicking the real virus in case of a viral infection, and that is intended to produce an immune response just like the immune response that would happen when you would be infected. And of course, the idea is that when you have been vaccinated, the immune response would already be there at the moment where you would get infected. So it would protect against the actual infection. So it's called vaccine after a Latin word vacca, which is the word for cow. And the reason for that is that the first vaccinations that were being done were somewhere in the 18th century, about around 1794 or so, where people were using parts of a cow pox to vaccinate particularly children for smallpox. So that's where the word vaccine comes from. And it's a very typical example because they would take a weakened virus. The cowpox virus would be similar to the human virus, but in humans, much weaker. Now, if we look at COVID and we look at the different vaccines, we may all remember that a year ago, when people started to talk about this vaccine, that we said, oh, this will take a long time. This may take up to 5 years. You know, the best results we ever had of getting a new vaccine were after 5 years. And what we know now is that we had a whole range of different vaccines after 1 year. And that is really a great achievement by science. And the types of vaccines that have been made range from traditional to very novel approaches. The traditional approach is the one that, for instance, Sinovac has been using. That's the approach where you take the virus, grow up the virus, and then denature, in other words, deactivate the virus, and use that to vaccinate somebody. So you inject the virus, but the virus is dead. The virus cannot increase in number, but the immune response will happen. So then next time when you meet the real virus, you already have immunity. There's other examples. For instance, the AstraZeneca vaccine is an example of where they've been using a different virus, an adenovirus, that can give you some cold symptoms, but is not very dangerous for people. And then they put a little bit of the DNA of the coronavirus in there. And that little bit of DNA is coding for one of the proteins of the coronavirus, and particularly for that part of the coronavirus that makes the virus enter human cells. So that's another approach. And then there is the third major approach. There's many different ones, but the third major approach, which was using messenger RNA. So those are the vaccines of Pfizer and Moderna. So a year ago, we had no idea what would work best. We knew that the traditional one, the one that Sinovac is using, probably would work because that's done many times. The one with the adenovirus had been used a few times, had been used for Ebola virus, for instance. We knew it was active there, but whether it would work here, we didn't know. And finally, The messenger RNA one, we were not sure at all, because that one had been developed over a number of years. So people think it was very quick. That's not quite true. People had been working on this technology for about 20 years. And the idea was to make vaccines for cancer. But once the coronavirus came around, the scientists got very quickly the idea that this might also work for this. So they started working on this microRNA, or on this messenger RNA. And what this messenger RNA does is it's entering our own cells and then makes our cells produce the viral protein again. And then the immune response will appear. So in all cases, the idea is that our body will make an immune response against the virus or parts of the virus. Is it 100% protective? Ideally, yes, but it's not the case. So basically, you can take that in two different parts. Is one, will it protect everybody who is vaccinated? And the answer is no. Even the best example, so the Pfizer vaccine is protecting for about 92, 95%. So there's still 5%, 8% of the people that do not have protection. And also when we talk about the protection itself, it's not the same in everybody. So in some, it will protect so they will not even get infected. You know, that's ideal. But in general, what it does is that it makes sure that people that otherwise would have gotten very sick, might have even died, or ended up in intensive care or on a ventilator or ended up in hospital, are only very mildly sick. And you know, that's the main goal, to make sure that the infection is not as serious as it otherwise would have been. And the reason that that is happening is that the vaccine has made that already you have an immune response. And the immune response is in two parts. So we are reading a lot about the antibodies, and people are being worried whether the antibodies are still there after half a year or 1 year or whatever. But the antibodies is just one part of the immune response. The most important part, in fact, is what's called the cellular immune response, which are the T lymphocytes, which recognize the viral proteins and next help other lymphocytes, the so-called B lymphocytes, to make these antibodies. So the antibodies are important because the best ones of those, the so-called neutralizing antibodies, can actually make sure that the virus is not even entering our cells. But the cellular immune response also makes sure that when cells are infected, those cells are being killed, etc. So what we know is that in the vast majority of people, there is a good cellular immune response, and also that cellular immune response stays around for a very long time. So when in time we will meet the virus again, the immune response can be ramped up very quickly and then help the B cells to produce new antibodies and take care of this infection. So that's really the goal.
Okay. Wow, I have so many questions in my mind right now. So maybe the first one that's right on top is that, so while my body is still trying to produce the antibody, that means that there's still a chance that I can contract the COVID-19 virus and I can still be a carrier.
Yeah, carrier is maybe not the right word. But basically, yes, you can still be infected. And the reason for that is that when somebody's breathing the virus in the air and you breathe it in, of course, you are still infected. And the virus may still be present in your nose or in your throat. And if that is the case, you may still breathe it out. It's much, much, much reduced in comparison to somebody who is not vaccinated, but it is still possible. That also is why we require people that have been vaccinated at this time, when only few people have been vaccinated, to still wear face masks so they cannot infect other people if they would become infected themselves. So that's why we are still very careful. The thing is that although you may be infected, you will not get seriously sick anymore because you have that immune response that will keep the virus in check in your body.
Okay, got it. So then, Professor, is there a difference between some vaccine who has got only one dose and those that has two doses? And does that mean that the ones with two doses is you need it is less potent than the one with one dose?
Yeah, that's again an interesting question. So basically, let's talk about these three types. The ones that are so the denatured virus, the Sinovac, for instance. In general, what we do in immunology is you immunize, and it takes about 7-8 days before there's an immune response that will produce antibodies. And then we know that when we wait for about 2 weeks, or you can also wait somewhat longer, and we give it again, that the immune response will become much stronger. So that's called a booster. It makes the immune response much stronger the second time around. So basically, for most of these, the case is that after one doses, the protection would be, let's say, 30% or 50%, and after the second one, it would go up to 70 or 80%. So that's why it's done that way. The two exceptions are the Johnson and Johnson one, and the one of, I think it's Sinopharm, one of the Chinese ones, which are one dose. What they have in common is that both of those have been produced by the adenovirus technology, where they put DNA of the coronavirus into that vaccine and into the adenovirus. And it may be that in that situation, the adenovirus stays around for somewhat longer time in the individual, and so the immune response is also for a longer period. That may be why there's a difference between those. In general, a 2-dose regimen is the normal approach, because that second boost will really help, and a third boost would probably even help more. The one shot is really helpful, particularly when you are dealing with people that are difficult to reach, where you are not sure they would show up for a second dose, etc. So particularly for such groups of people, it's very interesting to have this one-dose regimen. It's not like that a one-dose regimen is better than the other ones.
Okay, got it. So, Professor, I'm the type of person, if let's say I'm unwell, and if the doctor were to prescribe, okay, you need to have this 3 times a day, I will make sure that I'll take 24 hours divide into 3. So, same thing with this vaccine, right? The recommended duration between the first dose and the second dose is about 12 weeks. Now, what if, given that right now things are so chaotic, what if it's not done within this recommended period, and if it's much longer, say maybe example 4 months to 6 months later, what will this mean to my body?
Yeah, another question where perhaps we may not even have the full answer. Why do we say normally 2 weeks? Because initially it's 2 weeks. It's because we know that when we give a boost after 2 weeks, it will really work well. What we also know is that if we wait somewhat longer, 6 weeks, 10 weeks, 12 weeks, it also works very well. And in fact, it's been shown that after 12 weeks, the level of the antibodies would be higher than with a boost after 2 weeks. So 12 weeks is good. Why don't we say longer? Because it's really not been tested. So we don't have the answer. It's quite possible that it would work well as well, but we simply don't know. But there's another side to this coin. Most coins have 2 sides, and this one also has 2 sides. So the side of the coin that's good for a longer period, let's say 12 weeks instead of 2 weeks, is that one, we can immunize more people a first time and give them some protection. So that's good. The second thing is that when you do it later, the amount of antibody generally is somewhat higher than when you do it earlier. So that's, the 2 good sides of this coin. The downside of waiting is that it's been shown that when you have only one dose, your protection, for instance, against some of the variants, the South African variant, for instance, is not very good yet. So is maybe only 33% protection. And then you really would not want to wait till 12 weeks, because in those 12 weeks, you would still run a severe risk of contracting the South African variant. So basically, that's why it's better to stick to the 3 weeks, as we are doing in Malaysia now, rather than doing longer periods. So it's these two sides, and both have to be taken into account. But since we now also have the South African variant in Malaysia, it is better to keep the period between the first and the second shot to about 3 weeks.
Okay, so I guess maybe because I'm a little bit more worried, because I think there are a lot of people were saying that, oh, I can't even get my first appointment. So me being the first batch that's being vaccinated, I'm also a bit worried, like, will I even get my second dose before we reach the herd immunity? So maybe then the next question that I have is, does herd immunity means everyone getting at least the first dose, or is it the second dose, or what is herd immunity?
Yeah, well, herd, again, coming from cows, right? So
actually,
herd of cows. So this is also going back a long time, where people noticed that, when you had a herd of cows where many had already had the disease, that they would be more protected than when you had a herd where no one had had the disease. So here also, herd immunity can be achieved in two different ways. One is a herd of people that had the disease and survived. And when there would be enough, this would be called herd immunity. That's not an option in COVID, because way too many people would die to be acceptable. So that's why in all countries, basically, the government has said, no, we have to avoid that. We cannot just let the virus go. We have to have all sorts of protection. The second way to achieve herd immunity, of course, is through vaccination. And we need to achieve both doses of the vaccine in 70, 75, 80% of the population. So why am I giving a range? That also has to do with which variants we have, how infective these variants are. There's the original virus, then now they've got a new name, so now they got Greek letters. But originally, we called it the UK one, which is now Alpha, and the South African one, which is now Beta, and the Brazilian one, which is now Gamma, and so on. So, but basically, if they are more infective, we will need a higher proportion of people that are fully vaccinated. And the herd immunity only comes after the second dose. So we need to have sufficient people that have had both doses.
Okay, got it. So maybe for the audience, if you have any questions, please put in the chat so that we can address them. So that Professor can address them. So while we wait for the questions to come in, Professor, I have one more question. So because there are 2 doses, and I personally took AstraZeneca, I think at one point of time, KJ mentioned that we can actually choose which vaccine we want. So does that mean that, or rather, is it okay for me to choose another vaccine if I have already taken the first one with AstraZeneca and second one with, I don't know, maybe Sinovac?
The thing is that theoretically, it's fine. I'm a scientist, so the problem for me is to say that many of these things have not been tested. When we start out with a new vaccine, we go through all of these clinical trials for safety, for efficacy, and so on. We want to do certain numbers. We want to know how it goes exactly. For this, theoretically, it would work fine, because basically what you do is you get a first vaccine, the immune response is against the virus. You would get another one, and you would get a response maybe against a little bit different part of the virus, and theoretically this should work well. The problem is no real trials have been done with these combinations. So I would advise people to take the same one because that's scientifically proven. If there are good reasons why somebody should not take the second dose of one type, let's say somebody would have shown a strong response or an allergic response against, for instance, the AstraZeneca, it would be safe enough to take, let's say, Pfizer for the second one. That would not be a big problem. But the thing is that doctors don't really like to do it because it's not a scientifically proven combination.
Mm-hmm. And I suppose also it's because it's tested in different environments, different ways of testing. So to have two different types of vaccine in the body, so it's not actually proven how the body would react if it's two different vaccine, I suppose.
Yeah, it's simply, the experiments have not been done. As I said, theoretically, it should work fine, but for medicine, we are used to doing a trial and making sure it's fine.
Okay, sure. So we have got a question here. Well, I suppose there's just so many information out there on the internet. We've heard about the blood clot. We have not heard about any side effects for the other vaccine. So I suppose there's this question here on, does the brand really matter?
To be honest, not really. I think that all the vaccines that have been approved in Malaysia and have been approved by WHO, which are, the Moderna and the Pfizer and the AstraZeneca and the Johnson & Johnson and Sinovac and Sinopharm and so on, all have been shown to be effective and to be safe. So those are the two important things. And yes, there have been some side effects, particularly with AstraZeneca, but also with Johnson & Johnson. They are extremely infrequent. And if you compare the risk of coronavirus infection with the risk of this, there is such a big advantage in taking the vaccine that you really have to say that any vaccine is good right now. There is some hesitancy in young women, particularly with AstraZeneca, and many countries have decided not to use AstraZeneca in young women. But again, even in that group, your chances of winning the lottery are much better than the risk of getting those side effects.
But on the topic of women who are, I think, expecting and also breastfeeding, I think we have also been getting different messages. Like, I think at one point of time, it was mentioned that it's not okay to take AstraZeneca, and then suddenly there's a turnaround to say that it's okay. What's your opinion, Professor?
Okay. So the thing with both pregnancy and breastfeeding actually is that why was it initially not advised? Quite simple, because the experiment had not been done. So there were no clinical trials looking in women that were pregnant and no clinical trials in women that were breastfeeding. In the meantime, sufficient people have been vaccinated that were pregnant, knowing it or not knowing it, or were breastfeeding. And it is quite clear that there is no risk in pregnancy. And in fact, that when you look at breastfeeding, there's probably even an advantage. And the advantage is that the woman who is vaccinated while breastfeeding will produce antibodies that also will get into the milk. And in that way, give what's called passive immunity to the child. So the child actually will be protected also against the virus through the antibodies that the mother is producing. So it's in fact an advantage.
Okay. Yeah, it makes sense. It makes sense, Professor. We have got another question. Is vaccine AstraZeneca vaccine suitable for young people between 18 to 25 years. If I'm not mistaken, UK used Pfizer for young people instead of AstraZeneca.
Yeah, this all has to do with these findings in particularly some European countries that particularly younger women, but younger is not just 18 to 25, but would be also up to, let's say, 50 or so, that they had a higher risk of developing this very unusual coagulation disease than when you looked at older people or you looked at males. It's not a black and white difference, but the frequency is higher. It's still quite infrequent. So many countries are erring on the side of safety and now not giving AstraZeneca to young people. They provide them with a different alternative, in many cases Pfizer. I still believe that it is much better to become vaccinated, also to become vaccinated with AstraZeneca than not getting a vaccine.
At all. Yeah, true. Okay, this one is interesting because I've read quite a bit about efficacy rate. So maybe before we answer that question, Professor, if you can help us understand what is the meaning of efficacy rate and why is it different with the different vaccines out there?
Yeah, the efficacy rate basically is how well it works, to make it quite simple. And the different vaccines, I tried to explain earlier that it is, of course, dependent on the vaccine, but it's also dependent on the situation where you test the vaccine. So if you take a vaccine in a clinical trial and you take it in an environment in which there's a very high load of virus. So this example of the clinical trial in Brazil among healthcare workers during a tremendous epidemic in Brazil. So they were exposed to loads of doses, loads of virus every day. And there the protection then was 50%. In other words, 50% of them still were not necessarily getting sick, but they became positive because they were exposed to the virus. So in that situation, that's the most difficult situation in which you can test the virus, test the vaccine, and then the result may like that. If you test in a population where very few people are sick, you will find also that the protection is much higher because the people are not the vaccinated people are not exposed to so much and not to such high doses of the virus. So that is one reason why in the clinical trials there are some differences. So for instance, this difference between 50% in Brazil, 80% protection with the same vaccine in Turkey. It all had to do with how much exposure the vaccinated people had. So that's one thing. The other thing that's a very important concept is that there's a difference between what you see in a clinical trial and real life experience. And real life experience actually is the most important thing. And so to still take this same Sinovac vaccine in a small town in Brazil near Sao Paulo, a small town named Serrana, they've done an experiment, one can call it. So they vaccinated all adults in this town of 46,000 people with the Sinovac vaccine. And what it showed was that the protection, not just for the people that had been vaccinated, but for the whole population, so including the children that had not been vaccinated, was 95%. So they had achieved herd immunity. And when you have herd immunity, that's the idea of herd immunity. You're not only protecting yourself, but you're also protecting others. So a vaccine, and this was in a period in which the number of infections in Brazil were very high. So in Sao Paulo, things went very bad. Whereas in Serrana, where they had been vaccinated, they were protected. So this is real life efficacy showing that when sufficient people are vaccinated, there's protection for the vaccinated, but also for the people that are not or not yet vaccinated. So in that case, children, for instance.
Wow. So in such a big country, or like a vast country like ours, example, or even Indonesia, to reach to that herd immunity, it's so difficult. I suppose we can only go by state or by town and slowly spread outwards, I guess.
Well,
Okay.
I think Malaysia right now. So I think we had about one dose. Yeah, it's always important to know how many one dose, how many two doses. But I think we have about 3 million people that at least had one dose now. What's important is that now the vaccination effort is ramping up quite rapidly. So I think that the time is near where Malaysia will be able to do, 1 million vaccinations per week. When we can do 1 million vaccinations per week, I think when we look at a population that's 18 or older, that will be of the 32 million or so Malaysians. I think there's at least 10% that are under 18. So you deduct those. So maybe we need to vaccinate 28 million people. So that would mean that by October or something like that, Malaysia could have achieved, a 70 to 80% vaccination, two doses spread. So I think, and that's what the government is aiming for now. Initially, the aim was to have that done by February next year. Now the aim is to have that done somewhere in October. And I think that really would be very, very good. Now, what was holding us back? It was not willing. It was the difficulty of obtaining sufficient doses of vaccine. Because the first condition is, can you buy the vaccine? And that was very difficult because some countries, and I'm sorry to say, European countries, American countries, they were basically hoarding vaccine. So they bought way too much vaccine for their own, which they were not all going to use. I think Canada had 3 times as many vaccines reserved than they actually would need. So they could have given 6 shots to every Canadian. That did not make any sense. So now it's possible, it's been shown possible also for Malaysia to buy enough of the vaccine from different sources. So from Pfizer, from AstraZeneca, from Sinovac, and so on. And so for the next month, Malaysia will have sufficient vaccines to go much quicker. It's already happening. Some days now, around 100,000 people already have been vaccinated per day, and it's going up. And I think once we get to about 1 million per week, we'll be really doing well.
I think there's, despite the increasing number of cases, I think there's also that hope that we can raise towards getting majority of Malaysians vaccinated. I think we all just need to be educated and be equipped with all this information. Yeah, thank you, Professor. The next question that we have here, is AstraZeneca safe for smokers, as the blood clot forming is more prominent in these groups of people?
Yeah, interesting question. What is important is to know that the coagulation that is happening with the AstraZeneca vaccine is a very unusual type of coagulation, of blood clotting. Totally different from the types of blood clotting that you see normally. So in fact, there is no relation between the type of blood clotting that you would see in somebody who is smoking with the type of blood clotting that you would see in somebody with the AstraZeneca vaccine. So there is no increased risk for them. What is known, of course, is that the risk in general is higher. That's true, but it's not increased by by AstraZeneca vaccine because it's a different mechanism. The coagulation with the AstraZeneca vaccine is a very unusual one because it is leading to the production of antibodies against platelets, and platelets are the small blood cells that will lead to the clotting, and when the antibodies bind to it, then you get this clotting mechanism, and you get this very unusual situation where it seems like you have too few platelets and still you have lots of clotting, and that's happening because of these antibodies. So that's a very different mechanism from other types of coagulation. That also is, for instance, why heparin, which is generally used when you have a clotting disease, is not working in this type of AstraZeneca coagulation. Mm-hmm. So short answer is it's safe for smokers.
Or maybe they shouldn't be smoking.
It's not safe to smoke though.
That's exactly my point too. Maybe you should just stop smoking altogether. Okay, the next question we have here. Some people get side effects, but some others do not. How will we know if these vaccines are actually working?
Yes, good question. Of course, the side effects indeed are a good indication. So when you talk about the side effects of getting a bit of fever or a headache or feeling like you have a flu, etc., stiffness, it's a good indication that there's an immune response. But from the clinical trials that were carefully controlled, we know that also the people that did not get these symptoms still get a good immune response, are still producing antibodies and so on. So when you have the side effects, rejoice because you know it's working well. When you don't have them, don't worry because we know you still get an immune response.
I suppose this question also pops up because there were also videos showing that they do not get the 0.5 dose. So I guess people are also worried, like, oh, how come I don't have side effects? And mind games.
I know. Okay, let me say the following, that so if you don't have side effects, it does not mean you did not, as I said, you did not get a good response, because you might have a good immune response. The story about not getting the full dose, in fact, is not so terribly important. The dose we are getting is not a black or white difference between whether it would be 0.5 or 0.4. In both situations, you would get still a good immune response. Of course, the idea is to get a full dose. And I know that the concern came because people have to get a certain amount of doses out of one bottle sometimes. And then, the last one theoretically might be somewhat smaller, etc. But even if it's a little bit less, don't worry. It still will give you good protection. Because it's a standardized dose for all people, small people, big people, etc. And still, we use this one standardized dose. So it's more than sufficient for everyone.
That's very assuring, Professor. Thank you so much. Okay, the next one. If this individual had a history of anaphylactic reaction towards bird's nest, is it advisable to take AstraZeneca vaccine or other vaccine?
No, the only situation in which you should not take AstraZeneca vaccine or any vaccine, because this is really not has not to do with AstraZeneca vaccine, but has to do with any vaccine. The only reasons to not take it is when people had a serious reaction to a previous vaccination. So if you had another vaccinations for influenza or, for whatever, or when you had another medicine injection and you had a serious reaction against that, that's when you should not take the vaccine, but first look at, which vaccine did you have previously? What were the ingredients in that vaccine? What are the ingredients in the AstraZeneca vaccine or in the Pfizer vaccine? And make that comparison. So then you really have to go to the doctor and make sure that that comparison is being made. But that's the only situation. There's no other allergies, food allergies, and so on are really not a problem.
Okay. Professor, we have answered this question before, but I would like to attempt this on my own so that I understand what you have taught me so far. But please correct me if I'm wrong. So the question is, how long will the vaccine immunity last? So if I understood you correctly, it really is dependent on the body to produce the antibody. So the last time when it was tested between the first dose and second dose, it could be 2 weeks. But what we have learned is that even between the first dose and second dose, the body will also start to produce this immunity on our own because of whatever that's being injected to our body. Hence, it lasts, and the second dose is meant to be a booster. So am I correct in understanding?
Yeah, right. But the real basis of this question is how long will the immunity stay around? And what we do know is now that it is at least 6 months, because there's been people that were vaccinated 6 months ago and still produce the antibodies. What I'm saying is that we focus a little bit too much on those antibodies because that's not the only part of the immunity. In addition to the antibodies, there's also the cellular immune response of the T lymphocytes, which is very important. And perhaps some of you remember that a couple of months ago, there were also some reports saying that some people that had never been in touch with the COVID virus already had some immune response against the virus. And the reason for that was that COVID-19, this virus is not the only coronavirus. There are other coronaviruses that give us common colds. There's two that frequently turn up. And so some people will have had those infections with those coronaviruses and will have an immune response against those. And particularly, they will have this T-cell immune response. And those people already have more protection against the virus than people that never had such infections. So I think the bottom line is that once you have been vaccinated, you will have protection for a considerable period of time. We do not know yet how often we will have to give a boost. That is dependent on two things. One is how long will the immune response hold on with this one? And the second one is to which extent will the variants be different from the original virus? So when we talk about influenza, we know that there are so many different strains of influenza now that every time for vaccination, every year, we need to make a prediction for which strains to vaccinate for the next year, because some strains have been around 10 or 20 years ago, and all of a sudden they come back, and then we vaccinate for those. It is possible that in the future, coronavirus will become like that, and that each year we will need to think, will it be the South African variant, or will it be another variant that is likely to come this year, particularly during the winter, and may we need to give a boost for that? We simply do not know that yet. But, scientists are preparing for that. They're thinking about it. That's why it's very important to test which strains are there. You've recently read that Malaysia also has found, a number of South African variants and a couple of UK variants and so on. Another one, a Thailand variant. It's important to follow that so we know what we are dealing with. Maybe another thing that's important to know is that, when we are talking about these variants, and we are talking about variants of concern, and we are talking about variants of interest. So what is a variant of concern? Basically, what can happen when the virus mutates and leads to a variant is that a couple of different things can happen. So theoretically, the virus could become, much more serious, so leading to a much more serious disease than the original one. In fact, that has not happened so far. The second thing that can happen is that it's becoming more infective. That has happened. So the UK variant was more infective than the original strain. The South African variant was more infective than the original strain. So those are being called variants of concern. The third thing that can happen is that it changes to a degree that the immune system cannot recognize it as well. So that's why people look at whether it protects equally well for the variants as for the original strain. And in some situations with some of the vaccine, it's been shown that the protection against the variants is somewhat less. It's still protective, but somewhat less than with the original strain. So far, there's no major concern because all the different vaccines have been shown to also give protection against the variants, but that's one of the risks. So the three risks: more serious, more infective, or less responding to the immune response of our current vaccines. So far, it's all under control, but that's really what we're worried about. So that's why we follow all of the different variants, and that's why we want to know whether they respond well to the vaccine.
Wow. So that means our researchers and scientists have been working very hard in making sure that, they are on top of all the new variants that's popping up.
Yep.
And it has been more than a year. Wow. Okay.
Yeah, but this all has been done in a year's time. It's amazing. This is really a triumph of science. There's not enough appreciation for that. But, having the sequence of the virus in 2 weeks or so after finding the virus has never happened before in all of our history. Having vaccines that have been fully tested, found to be safe and efficient in such a short period has never happened before. And so that's not a reason to be worried. Everything has been done proper. Everything has been tested proper, by the ones producing it, by different bodies that investigate it, by WHO here in Malaysia, by the authorities. And only after that, they are being made available to the public.
Yeah. So there are a lot of things that has been put into the procedure. We have been following the procedure and the policies anyway. So there's nothing for us citizens to worry about.
That's true.
15 minutes into this, maybe we will take maybe a few more questions.
Yeah.
Okay. So let's look into another one. If I have a severe allergy to medications such as paracetamol, can I still get vaccinated?
Yes. Very short answer. No problem.
Okay. I think
because the reason is, maybe I should explain a little bit. The reason is there's no paracetamol in the vaccine. The only worry would be for products that you are allergic for that are in the vaccine. Then there would be a concern. But paracetamol is, the components of paracetamol are not in the vaccine. So there's no worry.
Okay. I think the rest of the questions were actually answered earlier on, maybe because we have viewers coming in a lot later. But I'm sure this video will be, it's already recorded and it will be shared. Maybe, okay, I think there's one here that he's a little bit worried, I guess. Is there an issue with using different vaccine brands for first and second dose, possibly due to limited supply? For example, first dose is Pfizer, while second dose is AZ. I think this was answered earlier on, but maybe
this is a slightly different twist on it. I think that in general, the approach is for the vaccinations, when you're getting vaccinated, that at the point where you get your first vaccination, the second dose is also reserved for you. So you get an appointment for the second dose 3 weeks later with the same vaccine. That's the general approach here in Malaysia. So in that case, there's no concern, because when you get your first doses, the second doses also is already secured.
Okay, maybe we will then take the last question here, Professor. Is it advisable to take vaccine if I am allergic to penicillins?
Yeah, that's fine as well, because again, there's no penicillin in the vaccine. So, all of these things, when you're not feeling certain, you can always go to your doctor and ask. But a general answer is that there's no worry unless it's been for anything that was in a previous vaccine or in a previous injection with a drug. So then you really have to talk to the doctor and make sure.
Okay, all right. We have an audience here who is afraid of needles. I'm not sure about this, but yeah, the last question is, any needle-free COVID-19 vaccination?
They're coming because, of course, it's quite possible to also sort of inhale, take it through the nose. They're not yet available. They will be coming. But I think what is a much better approach is you go and sit down, you roll up your sleeve. So that's one of the things to make sure when you go for your vaccination, to wear clothing where it's easy to roll up your sleeve.
Yes.
You look at somebody else who is near to you and you talk to them, and you will not even feel the injection. So don't look at your arm, look at somebody who's with you, talk to them, and then you will notice that the injection has been and you didn't even notice.
Okay, all right. Thank you so much, Professor, for taking the time in answering all our doubts, all our questions. I think it's such an important time to just equip ourselves with all this information. So maybe last one from yourself to all Malaysians out there, what's that advice that you want to give all of us?
Absolutely, go vaccinated. So, 3 things: vaccination, vaccination, and vaccination. It is so important, not just for yourself, but also for your environment. So you do it for your parents, you do it for people that cannot be vaccinated. That's why you are doing it. And on top of that, it's protecting yourself. But it will enable us to get out of this lockdown. It will enable us to return to a much more normal life. It will enable us to have economic activity again. And that's why we need to do it all together.
Yes, it's our social responsibility.
Absolutely.
Okay, all right. So just for everyone, this is health information provided for all of us in general. It's also for educational purpose. It is not a substitute for professional health advice. So if you do have any questions at all regarding allergies or side effects, please go and see the doctor. All right. Okay. Thank you again so much, Professor, for your time. And we will see you soon. Please take care and stay safe.
Thank you for having me. Bye-bye.
Bye.